Hello, my name is Nicole Bendish, and I'm an occupational therapy doctorate student at Rush University. Welcome to my doctorate capstone project presentation titled Occupational Therapy's Role in Supporting Engagement of Clients with Mental Illness in Healthcare Services. I would like to acknowledge a few people who made my research possible. My Rush faculty mentor, Dr. Olson, the Rush capstone coordinator, Dr. Costello, and my Threshold site mentors, Nikki Pashka and Kendall Wolf. I would also like to thank the entire Rush OT department and all of the members of Thresholds who participated in this study by sharing their stories. First, I'll start with the background. My capstone site was a supportive housing site at Thresholds, which is a community behavioral health organization based on the north side of Chicago. Thresholds works with Chicago community members who have diagnoses of serious mental illness, or SMI, such as bipolar, schizophrenia, schizoaffective disorder, and substance use disorders. These members benefit from the in-house Thresholds clinical team that provides case management regarding housing support, health management, and all other meaningful occupations that require additional assistance. Thresholds does not have an OT on staff, so I was interested to explore the OT role in this emerging area of practice. Here are some highlights from my literature review. First, I looked at personal factors, which are the features of a person that are not a part of their health condition. Research showed that patients who are at high risk for psychosis struggle with resilience and rely on passive coping strategies, which can be impacted by their personal factors. Next was the relationship between physical and emotional health. This shed light on why people use substances to cope with their mental illness and how a motivational interviewing approach can make OT interventions more effective. Third was how OT interventions impact general well-being and recovery for patients with SMI. These include understanding what recovery means for each patient, and that OTs must use models of practice that support positive patient outcomes. And lastly, I focused on gaining a better understanding of the Adverse Childhood Experiences, or ACEs questionnaire. The ACEs questionnaire is a series of questions regarding child abuse, child neglect, and household dysfunction. The literature shows that individuals with 4 or more ACEs are predisposed to serious health issues, including heart disease, stroke, liver disease, and more. Individuals with increased ACEs were also found to have decreased reported levels of well-being, decreased access to healthcare, and increased rates of unemployment. This research was based in the model of human occupation, or MOHO theory. The 3 main tenets of MOHO are volition, habituation, and performance skills, which all impact occupational performance. The 3 main MOHO guided the overall dialogue in this study regarding motivation towards occupations and discussing critical life events. Keeping these concepts in mind during our research helped keep our discussions person-centered by considering internal and external influences on occupational performance. This research is important because many clients who take part in OT services have mental health needs and a history of childhood trauma that permeates into adulthood. Individuals with serious mental illness also have documented lower levels of self-determination and may experience difficulty advocating for their needs to have their personal goals addressed in a clinical setting. Lastly, having a history of trauma can greatly impact an individual's ability to independently participate in meaningful occupations. Here are the 3 research questions I looked to answer through my study, focusing on healthcare experiences, mental health interventions, and then OT's distinct value. So here are my methods. This qualitative study used deductive reasoning to pull themes from interview transcripts and thematic analysis to understand participant life experiences. Participants were 9 individuals with SMI diagnoses. They were recruited by convenient sampling through a flyer at Thresholds. Inclusion criteria for the study was a diagnosis of mental illness, membership at Thresholds, and a minimum of a 5th grade reading level. I completed a motivational interviewing training and utilized this approach while working with participants to effectively guide difficult conversations relating to their life experiences. These one-on-one assessment sections ranged from 35 to 90 minutes. In the sessions, members completed a consent form and a semi-structured interview, which is the OPI, or the Occupational Performance History Review. The OPI has 3 scales listed here. After completion of the interview, members were provided a $20 incentive from the Thresholds Research Department. All meetings with participants took place in a private room. I met with the research director at Thresholds to gather demographic information on the 9 participants. The OP assessment consists of 3 items: a semi-structured interview, scales for rating the information obtained in the interview, and a form to record qualitative data, including a narrative slope, which you can see at the bottom of the screen. The OP touches upon occupational roles, daily routines, occupational settings, activity occupational choices, and critical life events. The interview is scored using the FAIR scale, so I ranked 3 scales on whether something facilitates, allows, inhibits, or restricts occupational participation. When tested, these 3 scales of the OP display good internal consistency. Descriptive statistics were used to summarize the demographic information I collected. Thematic analysis identified the theme areas and defined the value of these themes to the patient experience. The steps of thematic analysis, as outlined by Braun and Clark, allowed me to better understand participants' experiences with the process outlined on this slide, which leads into the results. OP narratives came from 9 participants who were majority white and male. Participants had an average age of 54 and an average ACEs score of 4.78. The most common ACEs category was emotional abuse, with 7 out of 9 participants. And then on the right, you can see the breakdown of participant primary diagnoses. Here are the OP assessment interview score averages. The first 2 client measure scores seen here circled indicate that participants experienced decreased occupational identity and competency. Conversely, perception of occupational settings here is above average, indicating participants feel supported in their environments, which include their Thresholds residences. So 3 overarching themes emerged from the interviews. First is perspective on healthcare services. Second is person factors. And third is sense of autonomy, with their sub-themes listed here. All participants interviewed described their past experiences working with healthcare professionals. They recognized their treatment by medical staff in the hospital and their relationship with their current outpatient providers. The 2 sub-areas of positive and negative experiences encompass the opposite ends of the spectrum of patient experiences in healthcare. So starting with positive experiences, structure and balance were noted as important environmental factors related to a positive healthcare experience. One participant recounted his experience inpatient, stating the good parts. The good part was I got better, I got off the unit all the time, took my meds, met some interesting people. Members also noted that getting connected to Thresholds through a hospital admission was a positive experience. Regarding negative experiences, many members recounted multiple hospitalizations, one patient stating they had over 40 admissions total. Participants addressed the need for increased communication while inpatient, saying things like, I'd like them to not just assume I'll be okay, just ask, I felt neglected. Overall, the circumstances of admission had an impact on the participant's healthcare experience, seen in the other quotes listed here. The next theme area is personal factors. The 3 sub-themes of family support, social support, and absence of a romantic partner highlight the impact of personal factors on the participant's life outlook and values. One participant recalled the impact of losing a family member on their mental health on the left, while another identified the value of their family to them. Many participants lack these close family relationships, though, and other social supports were identified. One person identified his homemaker as a support, while another discussed her lack of a social circle. Lastly, on the right, 4 of the 9 participants noted the absence of a romantic partner in their lives. One statement that particularly stood out was, I don't need to be with a man to have a place to live, or to feed myself, or to take care of myself. And then lastly, the sense of autonomy. Autonomy is described as freedom from external control or influence. This independence is different for individuals with mental illness due to the occurrence of occupational dysfunction or having negative experiences while engaging in daily activities. This concept of autonomy was frequently brought up, and one member eloquently expressed this by stating, "As long as I've got my freedom, I'm a happy camper." Occupational role fulfillment is defined as gaining a sense of meaning from participation in roles in everyday activities. One member recognized the impact of their SMI symptoms on their ability to work here on the left. On the other hand is the lack of role fulfillment with being unemployed. One member here in the middle talks about unfulfillment and the connection to an inability to manage active symptoms. And many participants described maintaining stable housing as the most important thing contributing to their well-being. A majority of participants recognized that their biggest success was surviving homelessness. Finances and being fiscally secure came up in interviews as well, seen here on the left. Another member highlighted his goals for the future financially as well. And then on the right, maintaining sobriety or smoking cessation were described. One member here provided honest answers to his doctor regarding his substance use, and another member discussed his choice to be sober. And then the discussion. So we must learn of a person's established roles, routines, and interests before starting new OT interventions. This research here shows that using a MOHO-based assessment like the OPI with clients can increase rapport and give perspective on a person's life experiences. Using MOHO can ensure interventions are client-centered for people who often feel like another number to their medical providers. These findings also promote the distinct value of OT in the interdisciplinary team as we identify the client's roles, routines, and interests, and relay this information back to the clinical team to assist with safe discharge planning. The narrative stories in this research describe feeling unsupported and neglected while admitted. OTs can increase support for patients by learning about the available resources in the community for people with SMI. These may include supportive housing organizations, 12-step meetings, food pantries, and beyond. When possible, OTs must work with a social worker and the rest of the team to ensure the patient has a plan for when they leave the hospital. This research supports prioritizing the patient perspective in order to create a positive experience. In this sample, these participants have a history of ACEs. Therefore, gathering the patient's ACEs on intake or contacting their community behavioral health center to get that data would be helpful. Lastly, despite the chaos of a hospital admission, an OT session can provide a patient with occupations based in routine and a just right challenge. Gathering the occupational background in addition to the ACEs scores could leave patients feeling supported during their healthcare experiences. Due to the small sample size, this research was also conducted at only one site. These findings are not indicative of the experience of all people with SMI. Lastly, there was a financial incentive, which may have impacted interest in the interviews, and a thematic analysis is subjective, which may have impacted the theme areas addressed. In conclusion, OTs and the healthcare team must use the insights from these narratives to empathize more with their patients and use the ACEs questionnaire or MOHO assessments like the OPI to identify mental health concerns. We as OTs must educate ourselves on mental illness through continuing education courses, educating others in the team meetings, and educating patients in session when appropriate. OTs can help patients through their role as members of the team and by focusing on self-determination in session with patients. Patients who can advocate for themselves in their treatment and verbalize their concerns or questions will have overall better healthcare experiences, but clinicians need to provide those opportunities for patients. The findings from OPI interviews shed light on how SMI is addressed in healthcare settings from the patient perspective. OT as a profession has the power to change the social norms in our hospitals, clinics, and communities for people who require this individualized care the most. This goes beyond people who have a diagnosed mental illness and is applicable for patients who are experiencing a form of trauma after any physical disability or brain injury as well. Finally, no matter where we are working, in a school setting, acute ICU, outpatient clinic, inpatient rehab, OTs need to be aware of our therapeutic use of self because our relationships can be healing. Thank you so much for listening. And here are my references.